the Central West District and the Ministry of Health and Long-Term Care, where she led the development of planning reports to guide primary health care and system reforms. She holds a Bachelor of Science from the University of Toronto, Master's in Environmental Studies, Health Promotion, Policy and Planning from York University in Toronto. So, Elaine, if you'd... Do you want to do it here? It doesn't matter. Do you want to do it here? Yeah. Okay, that's good.
Yeah, it's better to do it from there. Good morning, and thank you very much for the opportunity to present to you today on the Health Council's report entitled Canada's Most Vulnerable, Improving Healthcare for First Nations, Inuit, and Métis Seniors. It's a whole report dedicated to improving the health and well-being of First Nations and Inuit Métis seniors. I was invited today to present on the overall findings in this report and then some of the specifics that we learned about the non-insured health benefits program. As Benita was saying, the Health Council was established through the First Minister's Accord to report on progress in the Accords and how they are improving healthcare system reform, and also, most importantly, to spread innovative practices across the country. So to report on policies, programs, and services across the country that are improving health. And the Health Council's website has a health innovation portal where all of these practices are stored. So in addition to reporting, we also took on a multi-year project on First Nations, Inuit, and Métis health. The first project was on understanding and improving maternal and child health. The second report was entitled Empathy, Dignity, and Respect, Cultural Safety for Aboriginal People in Urban Health Centers, and then this report. The benefit of the Health Council reports, we report to government. We also have a communication strategy behind all reports, and it's to lend voice to issues that aren't often heard, discussed, make their way to the Canadian public, and so we have had impact in directing comments to government, to health providers, to universities. The reports get used in teaching materials, government documents, planning documents, and so forth. So for all of the reports, we go across the country, have interviews with Aboriginal leaders, governments, academics, health providers, health managers, and bring people together in regional meetings from across the country. For this particular report, we met in Vancouver, Winnipeg, and Ottawa, where we brought people together from across the country. And then we also held focus groups in Inuvik, Iqaluit, and Goose Bay. The report is organized in two sections. There's a commentary report that discusses pressing needs of First Nations, Inuit, Métis seniors that we heard about across the country. A section called Pressure Points of Politics, which gets into some of the health funding issues, and a section called Changing Landscapes and Key Approaches to capture the innovative practices that are happening across the country in addressing the pressure points and the needs. They're all captured in an appendix. Everything we heard about is in an appendix with contact information at the back of the report. Then we've profiled in this report section on innovative practices where we profiled 12 stories in depth. We selected practices that were addressing needs that were common across the country, and we tried to pick First Nations, Inuit, and Métis communities to be represented and, well, from across the geographic area. The story that I'll talk about today in the report is number 9 in the corner, and it's the First Nations, Inuit, the non-insured health benefits program in the Atlantic region that's adapting their program. You'll also note, though, that number 4 featured in this report is the shared care model in Peter Valentine Cree Nation. I've included some extra slides in here around the pressing needs of First Nations and Inuit Métis seniors that I'm not going to go through in detail, but you have them for your context just in the interest of time so I can focus on the non-insured health benefit programs. Different communities across the country, for sure, are very diverse, but many common challenges from the effects of colonization right through to social determinants of health, problems with a lack of home and community care, long-term care, palliative care, housing shortages, very complex needs and very complex to deliver care in rural and remote communities. And you heard the previous panel talk about this, and we heard this across the country as well. Healthcare is compromised and complicated, and mostly because of the poor communication, the jurisdictional disputes about ultimately who's responsible, lack of collaboration, underfunding is a huge problem too from Aboriginal Affairs Northern Belt Canada. Problems experienced across the country resulting in significant gaps and overlaps in care. First Nations communities are increasingly taking on more responsibility to direct and manage their care through a variety of transparent arrangements. And on the positive side, this allows for flexibility to meet community-specific needs. But on the negative side, it takes time and support to build this infrastructure, and service capacity and partnerships can easily exceed seniors' needs. And so there has to be additional changes taking place. When we visited across the country, we heard, no surprise to you, that the non-insured health benefits program is a source of frustration. It was described as being an underfunded, bureaucratic program with excessive restrictions and rules that are hard to understand. We heard that navigating the non-insured health benefits program in terms of what's covered is challenging for seniors. They're requiring help from already overworked providers that have limited capacity to help. Large numbers of applications are being turned down, leaving seniors in poverty without medication, without supplies. Appeals happen, but they're extra steps that require time, again, overburdened staff. Lots of paperwork, physicians' signatures required for even the most minor approvals. The requirement of approval of coverage in advance of medical travel, transportation, or for escorts results in huge delays in care, of medicine, supplies. This is placing seniors at risk for worsening conditions, hospital admission or readmission, and reduced quality of life. Escorts are not always approved, and leaving seniors stranded and vulnerable, literally stranded in airports and various locations. We heard awful stories. Métis are not covered by the non-insured health benefits program, but live in the same rural areas and suffer from the same problems. We did hear about changes that are starting to take place across the country. So in BC, where the Authority for Benefits has been transferred to the new First Nations Health Authority, this is allowing them to redefine the program to improve efficiency and effectiveness according to their own priorities and the health and wellness model that they have as part of their vision. At the time of this report, they were very early on and didn't have more details, but BC is certainly a model that everybody's watching. Nunatsiavut, a self-governing Inuit region in northern Labrador, and the non-insured health benefits program is directly managed by the Nunatsiavut government, and we heard that this allows for resources to be moved across departments in ways that create a lot of flexibility that wouldn't happen when the federal government was managing the program. The Council of Yukon First Nations have non-insured health benefit navigators. We know that other regions do as well. The Council of Yukon First Nations was saying that's part of the story to help seniors and families navigate through the system, but they are also investigating whether or not they should take on administration for the program, and so they did a capacity assessment, spoke with their managers, and they were, at the time of this report, also investigating, look at the BC model. What are the risks? What are the benefits? What are the pros and cons? What does it mean to take administration on for this program? What will that mean for the relationship with Ottawa? Will they be able to handle the administrative burden? So they are doing that. Health Canada, the First Nations Inuit Health Branch, we heard, had a quality improvement framework, and we're looking to make improvements across the system. At the time of this report, the people that we spoke with on the front lines weren't yet seeing any of these quality improvements. I'm going to tell you in some detail about the program on the Atlantic Coast, adapting the non-insured health benefits program to meet the needs of First Nations elders. So there's a strategic action plan. The elders expressed a number of ongoing problems with the First Nations Inuit health programs. As part of a new strategic action plan for First Nations elder care, they're working to improve the programs. The NIHB Atlantic has a co-management committee with the Atlantic First Nations chiefs called the McMallity Atlantic Health Board. And back in 2007, the Health Board established priorities that included elder care and specifically looking at options to help First Nations elders stay in the community for as long as possible, as well as addressing cultural competency, quality of care, and access to family for those who are admitted to long-term care facilities off reserve. So reviewing the non-insured health benefits program was a priority. So policies and requirements, of course, are established at the national level, and they can't easily be changed. But the regional branch was looking to review the programs from the perspective of whether the region had any flexibility to make changes for the benefits of elder care, and beginning with what aspects of the program are within the region's jurisdiction to design or modify. So they developed a policy lens tool called the Elder Care Assessment Tool, and that was applied to the medical transportation component of the program. One of the issues that elders had identified was the requirement for pre-approval to cover the costs of non-medical escorts to travel with them to appointments. So prior to the review, all First Nations people required pre-approval for every single appointment. And for elders with complex health needs or whose language wasn't English, this meant a lot of paperwork and a lot of delays. So as a result of applying the tool, it was learned that while the regional branch could not remove the pre-approval requirement, there was flexibility to change the procedure for people with chronic health problems or translation needs. And now they only needed to seek approval one time a year and to have for the medical escort to accompany them to all appointments. And also they changed the request form so that it was clearer, easier to answer, and more easily to determine eligibility. Another area that was explored for improvements was access to prescribed medications. Some are automatically covered, but others need to be approved by the Non-Insured Health Benefits Drug Exception Center in Ottawa. So the pharmacist needs to call, initiate the review, and then the drug center will send the paperwork to the health professional who prescribed the medication. Sometimes there's a breakdown, the pharmacists don't call, the proprietors don't fill out the paperwork, and the result is that the medication is denied. So FNIB Atlantic looked at the medications that were being rejected and to identify the top medications being requested, and they did learn that once approved, most were approved once they were reviewed. But in those instances where the pharmacist didn't call, the regional pharmacist at the FNIB branch did contact the pharmacies and reminded them about the process, and also sent the results of the work to a working group at headquarters in Ottawa. This contributed to some drugs being moved to the category where they are automatically approved. And the regional pharmacists also created formularies that identified appropriate substitutions for common medications, so that if the drug, if someone is prescribed a drug that requires a call, pharmacists can choose an alternate drug that is automatically covered. So it became clear that the tool had the potential to make a difference, and programs were being reviewed. The FNIB Atlantic did have flexibility to make adjustments in the procedure for medical transportation and to think creatively about what to do next. So the tool is still in its infancy, but through continued discussions, they're going forward and they're looking at other aspects of the programs that can be changed. FNIB Atlantic is working with the committee to review now the Aboriginal Diabetes Initiative, and that review is expected to be completed this year, and the committee was committed to reviewing new programs every year. So they have a simplified process for paperwork for non-medical escorts. Fewer medications are being declined for coverage, and the regional office does have some flexibility to make change within the overall national policies. And some of the key components that made this work are the partnership and the joint working group with First Nations, the new tool. And we heard anecdotally also that the regional director is a nurse. She's able to provide a patient-centered perspective rather than an administrative perspective, which helps quite a bit. Overall, many other changes, and all of these are captured in the report, are taking place across the country. Bringing care to communities and reducing the reliance on medical travel is huge through telemedicine, through video conferencing, through Teams. BC, in their changes, are going about this in a big way. When the specific needs of Aboriginal seniors are included in provincial aging at home strategies. That is significant. Partnerships and agreements are eliminating disputes. When health authorities have clear and uncluttered information about the provincial programs, and they can provide this information through trusting relationships with communities and partner on a case-by-case basis to navigate what is it that clients need, what is it that is available to them, what is it that should be available. It's making a difference. Shared caregiving and pooling resources such as Peter Ballantyne Cree Nation, when there are dedicated health centers, case managers, discharge planners, and navigators, like you heard from the last conversation, this is making a difference in helping seniors and their families to navigate the maze. We heard about online professional development and the use of non-regulated community health professionals such as community health aides to help support recruitment and retention and provide care in communities. Consulting seniors and doing detailed inventory and analyses to gather health data, what is available, what are the health issues, in order to support planning and policy. We heard about programs that combine federal and provincially funded programs together on reserve, such as in Bella Coola, and creating equitable service for everybody, First Nations, non-First Nations. Programs that integrate traditional culture and traditional and cultural activities are very significant for improving health and well-being. Slowly, it seemed that the federal, provincial, territory authorities and health authorities are stepping up. There's clearly a lot more work to be done. We suggest in the report that there really needs to be a shift for true equity, that care has to be brought to communities, rural and remote communities. The current focus on medical travel is hugely expensive, exhausting, challenging, frustrating. Some problems can be reduced, but the focus should really be on bringing care to communities. We heard from frontline providers that when they are able to separate the politics from care delivery and build relationships with between Aboriginal and non-Aboriginal organizations and providers, that helps. And governments really must clarify their roles and responsibilities, working in equal partnership with First Nations, that the first contact, first pay principle apply, and there's no more disputes over who pays. Regarding the non-insured health benefits, the NIHB regions appears do have some flexibility, and there's the value of a tool that's jointly developed and becomes part of a process where a shared commitment is developed to improve the health and well-being of Aboriginal seniors. It's a practical means, and together with national quality improvement initiatives, perhaps there's an opportunity at this time. We heard from participants that they found it valuable to be at the regional sessions to hear about what was happening from others across the country. It gave them new ideas and to perhaps bring back to their communities. So the Health Council hopes that this report will stimulate some new discussions and identify some new possibilities on how First Nations, Inuit, and Métis seniors' health can be improved. Thank you. The report, I've left a copy here online, but it's also available through the Health Council's website, and if you want to go directly to some of the stories, you can go right on to the portal. Thank you. If I could just say one thing, I'd really like to acknowledge Benita, Dr. Beatty, and her work, because there's actually very little written on the needs of elderly First Nations, Inuit, and Métis people, and it was her research that helped us get started. And she provided a lot of support for helping to identify some of the innovative practices across. So thank you, Nina.
Okay. Thank you, Elaine. So we now have Denise Bowden, who promised to talk about medical transportation.
Good morning. Welcome to the elders, the leadership this year. It's great to see the huge turnout, the counselors, health staff, and everybody else that's interested in healthcare for First Nations people. Yesterday I did a very short presentation on what non-assured is. And it's not my program. I'm a retired federal civil servant. I no longer work with the federal government. In my former life, I was the director of non-assured. And during my tenure with the government, there were certain things that you were not allowed to say. There were certain party lines that you had to follow. And basically, there was a gag order in effect on all of us. I have now passed my 1-year period. I can now say what I want. Isn't that wonderful? So today, what I've been asked to talk about is a little bit of the history of the program and some of the issues that I have seen over the years and some of the changes that have come down. So I'm going to try and summarize it to the best of my ability with the limited time, because I can talk about the wrongs and I can talk about that for the entire day. But I tried to focus my presentation on some of the big picture items and some of the changes that have come down over the years that have hindered not only the providers and the nursing staff in the communities, but also it's created a lot of hardship for our clients. And when the program first started, or when I first came to the program back in 1989, at that time, they were just starting to develop benefit lists. They were starting to look at policies. They were starting to look at the MedTrans program. And so it's taken a number of years for the government to actually catch up and develop their benefit lists and policies. And in 1995 is when it really kicked off. The Chiefs Committee on Health brought forward a number of recommendations to non-assured. And they told non-assured that they wanted benefits that were portable. They wanted the ability to be able to take your benefits from one province to the other. They wanted standardization so that you knew what to expect when you move from one province to another. Because at the time there was such a disparity amongst regions. Everybody had their own list. Everybody provided. Everybody just paid, basically. There's really not a lot of standards. So back in 1995, up to the early 2000s, headquarters was quite small at the time. NIHB was roughly about 30 people. And that included all their support staff, their consulting staff. So it was a very small, unique group. And as regions, we had the ability to sit with headquarters and develop a lot of the benefit lists. We had the ability to develop policy with them. They listened to us. They considered our words, and they took that into consideration when we were writing the policy. We had the ability to have input when they were looking at provider qualifications as part of the benefit lists and part of the process. So it was a great partnership that we in the regions were able to take the voice of the people forward. And some of the youth that have been around for a number of years will remember in the early 2000s, there wasn't so many restrictions. There wasn't so many limits. You could access things a lot more quicker than you can today, despite having emails, fax machines, and texting. It's just the process is slowed down to the point where clients, a lot of times, will receive the approval long after they don't need the item. Today, headquarters has grown to approximately 150 staff. That includes a staff that provide approval for dental, the drug exception center. They have a number of consultants. They have an entire negotiating unit. It's a very huge department now. And the mood has also changed, or the environment has also changed. Staff no longer have the ability from the regions to speak to headquarters and have their voice heard. It's basically come down to a dictatorship, which is one of the reasons when I left, I really was not, I wasn't upset in leaving. I felt that I no longer had a voice. I was no longer effective in my position, and therefore it was just time to leave. and maybe do something different where I felt good about myself one more time. Over the last 10 years, that feeling was no longer there. It was not a sense of pride in representing my region, and I didn't have a sense of pride in being able to bring the voice of our people forward to headquarters, because there was no opportunity for them to listen, or there was no opportunity for us to say what we needed to say and be heard. A lot of the work that needs to be done, in particular in medical transportation, here we get into the transportation Benita likes. The framework of the medical transportation program was developed back in the late 1990s. And in 2003, it became a document that was circulated and then was updated again in 2005. In the updated document that came out in 2005, regions thought we had input into the document, yet when it came from the printers, a lot of the items that we had recommended changes be made were not appearing in the document. When we consulted with headquarters about some of the changes and asked them why they were doing that, the response came back that it was felt that their words are better than ours. They knew more than the regions did, and this was the way it was going to be. So at that point, it started, again, becoming that dictatorship that we've seen coming. There's been a number of changes over the years that have come down, and we've seen the effect on clients. And the biggest one, and we heard that this morning, the biggest one was the discontinuation of hospital-to-hospital transfers. That was a huge one for our region. It was the cost was not that great for what I think anyway. It was about approximately $350,000 annually. But it also meant that those higher level tertiary beds in the bigger hospitals was freed up for the really sick people. And it meant that the client can go back home and recuperate at the home hospital where they were closer to family, closer to friends. I believe it had a great effect on them in terms of their recovery. But that discontinuation created a lot of issues. And in 2000, I'm going to looking at Darlene for this one, I believe in 2006 there was a task force that looked at a number of medical transportation issues, and one of them included the hospital-to-hospital transfer. At that session, I had requested that one of the health districts come forward and speak to the group on the innovative way that they were doing hospital-to-hospitals. One of the health regions had actually had a system in place where the ambulance was in town, they got paid to go there, they got paid to come back. If you're there anyway, you can pick up the client and bring them to the home hospital. It was a very unique way of doing service, and it was not just limited to First Nations. It included everybody within their health region. So they provided a really good service that I thought was unique. It was a thinking outside the box. When we invited the gentleman to come and speak at our group, the province took him aside that morning, took him for breakfast, and he amended his presentation when he came and spoke to us. And he has now since left the health region. He left that region about 2 months after that incident, so I'm sure that there was some nudging out the door to say. So there are ways that the services can be provided, but again, that means working with individuals. And Eric spoke this morning about the private ambulance operators, and that has been the biggest problem, is getting those operators on board, because they are private business people. They want to get paid for going, and they get paid for coming back, but they also want to get paid an additional trip for that same service, despite being there. So, one of the things that I think as people we need to look at is how do we use all those services? Non-insured is already paying. Let's use some of it. Let's find a way to make it work for the people. Yesterday we heard A number of the providers talk about the limits that are being placed on things like catheters, incontinence products. Those, again, are in what I'm calling nickel and diming from headquarters. People don't want to be wearing a TENS. They're not going to misuse them or abuse them, despite what some people think and say. I don't know of anybody in here, or even myself included, that would want to put on a tent and wear it for 4 or 5 hours when it's messy or smelly. Even a baby doesn't do that. We all keep our children very clean, and we make sure that their diapers are nice and clean. There's no reason why our people cannot have that same kind of service or product that will help them. There's limits on oxygen. That has slowly been coming down. We've seen a number of people, and I've talked to a number of clients during my years with the government, where clients were afraid to leave home because they didn't have enough cylinders, and they needed the cylinder to go shopping or to go to their medical appointment. So they really had no quality of life. They didn't get out. They didn't get out to the community. They didn't get out to visit family or friends. They basically stayed home, close to the machine. That, in my opinion, is not a good quality of life. We've heard a number of people yesterday and again this morning speak about the excessive information required from NIHB to provide a benefit. And I'm going to use the example of one of the nursing staff that I've been sitting with for a couple of days in a bedpan. A bedpan cost about $20. To get that bedpan approved, you need a prescription from a doctor, which means that you now have to take the client all the way to the doctor if you can get an appointment. There's medical transportation. You now have a doctor that is going to be billing for the service just to get a prescription for a bedpan. The total cost of that bedpan could be anywhere from $100 to $350, depending on the transportation costs. It's excessive. It's not required, in my opinion. We have qualified nursing staff in a majority of our communities that can do that. We have nurse practitioners that come in and they can do the same thing. So placing that excessive burden on the physicians is, in my opinion, is just not right. We all have difficulty getting an appointment when we're really ill without taking up a physician's time to write a prescription. I'm aware that this has been a difficult for some of the nursing staff in a few areas when it comes to bandages for clients that are being discharged home, and there's wound care involved. So again, that's just another example of the excessive requirement of NIHB. In my opinion, every time there's an incident or there is a bit of a misuse of something, they bring down a national policy or they bring down a change that affects 600,000 people across Canada. Just to be punitive on one or two. That's my opinion. I've seen it. I can give you examples over and over. We've seen allied healthcare disappear in Saskatchewan, and it's disappeared nationally across Canada. Chiropractor services also went by the way of the dodo bird in 2003. They took that away as well. It was not a huge program, but it was a much-needed program. Chiropractors provided services where people did not have to go on medication. And I know not everybody wants to be on medication. I certainly hate medication, and I know a lot of people do as well. And I would much rather be able to go to a chiropractor to fix my back than to be sitting there taking painkillers for the next 2 weeks. Podiatry is another one that is very dear to my heart, because many in my family and my friends, and I know there is a huge segment of our population that have diabetes. Yet podiatry is not being covered. In Saskatchewan, we defied headquarters, and it's still being paid for by the region. It's not covered by NIHB, but it is. The region has found a little bit of money to be able to fund this particular program. And I do think it's very important that for people that that have diabetes, that they provide good care for themselves in terms of their feet, so the ulcers will heal and they don't have the limbs amputated. Yesterday, there was a mention of coordination of benefits, and again, that's another one that is going to affect all of us. For many of the band staff, they do have an insurance plan, and part of what's happening nationally is that they did a sweep, and just so that you know this, it's already been done. They've already did a sweep within the system itself, and they took pharmacy and they took dental. They did a sweep in there, and they took a look at the number of people, and they took a look at the people that actually told the provider, you have an insurance plan. So now that they have that information, it's now on your file in Ottawa. And what they're moving towards is that they're moving towards to being able to link all of their systems together. So the next time you go to an optometrist, that optometrist may say, oops, Denise, we're aware that you have an insurance plan. You have to use that insurance plan before NIHB will provide. Now, most insurance plans that I've seen, and Helen can probably confirm this, is usually around $200 is the minimum. $200 is not enough money to get you an eye exam and eyewear. An eye exam by most providers right now runs about $90 to $110 per visit, which leaves you maybe $110 or $80 for eyewear. When you go into to pick out and select your eyewear or your glasses, that provider has marked up that frame at least 400%. What you see on the wall is their markup. Their actually purchase cost for a frame, like mine for example, is probably about $23, $24. The rest is all markup. And then they add in admin fee. They add in the cost of lens, which is a real cost. They might throw in a case for your glasses, which they say costs them $10, $15, which probably costs them $1.50. So there is a huge markup in optical. Now, once you use your insurance plan and you spent your $200 and your glasses cost you $400, you now have to send your claim into your insurance company and wait for your check. So when you get your $200, you send your receipt to NIHB next, and they will apply their rates. So you might get a check for $57. So meanwhile, you've lost all your money, plus more. I tell people, and I'm not ashamed to say this, I'm telling people, if you have an insurance plan, you don't have to tell anybody you've got it. It's nobody's business but yours. I'm also aware that there are some pharmacies that are asking clients if they have an insurance plan. And I know of one incident where there was a client that basically told the pharmacist that it was none of their business, and they refused to provide her services. By the way, that whole process may take up to 3 months to get all your money back. NIHB is not a very quick payer in terms of reimbursements. Methadone. I love this methadone. I tell you, it's enough to make anybody go on drugs. In Saskatchewan, when I left the government, the methadone program was at $1.2 million annually and growing. And that's just the cost of the drug. It didn't include transportation to access the methadone. In my opinion, the methadone program, and we heard, I don't know if Colleen is here today, we heard Colleen, one of the staff from one of the hospitals, speak about her issues with the methadone program and the clients. The program itself basically in Saskatchewan and many of the regions, has no teeth. You can come on the program. Yes, you may not be successful first, second, third, fourth, fifth try. You fall off the program. You come back on the program. You fall off the program. This is one of the few benefits that has no limits on it. They have not put any kind of limits. There is no requirements in terms of to access the program. There's no requirements to receive counseling. The harm reduction program says that they do counseling, but when you go down there and actually speak with them, yes, they make an appointment. Client doesn't show up. There's nothing they do about it. Client continues to receive their meth. Not everybody is a bad client. There are some really good clients out there that are making sure that they're following the rules and they're on the program because they want to stay healthy, they want to get clean, they want to get off the drugs. But a large number of them, and I know many of the health directors talk about this and can probably give you a lot of examples of the meth program and what it's doing. But a lot of the clients, what happens is that they will sell the meth. And I'm trying to remember who said that yesterday, I think it was Chief Thomas that talked about clients that's selling their meth. We know clients go onto the program when their street supply dries up. So they will go back in the program until they can find another supplier. And again, they come off. The program itself, I believe, is a good program in some sense. But I think the funds that are being spent could be better managed and spent somewhere else. Why not take that program, link it to counseling, give it to the communities? You guys know better than anybody else how to manage that program. And I know many communities don't want to because it is a difficult program. But I think there is ways that it can be managed and it can help those clients that are serious about their health. Put counseling services available to them. There are other things that you can do. Make it a requirement that they have to get counseling. There was a pilot running in the Atakakoop First Nation. I don't know if it's still operating. It's still operating, Darlene? I thought that was such a unique program, and it was started by the community. It's run by the community. And the last time before I left, I knew it was operating quite successfully and very well. And I think those kind of programs should be supported 100%, and they should be funded accordingly without the band having to scrape together money or the chief having to dig into band funds to support this. So there are other things that can come with this program. Yesterday we heard one of the speakers talk about the program is reactionary and is not prevention. And that's absolutely true. Diabetes is the one that I spoke on earlier. And if rather than spend a lot of money on prosthetics or prosthesis, which cost about $10,000, why not invest in a pair of shoes for our clients? $250 pair of shoes for a client that has diabetic ulcers is a huge investment, and it'll go a long way in preventing the amputation of that limb. In the early 2000s, headquarters did run a pilot project. There was supreme pressure from the regions to look at the diabetic shoes. And so they ran a pilot project in 3 locations across Canada, and none of them was in Saskatchewan, by the way. But that pilot ran for a year, and what they did with that pilot is they attached guidelines to it. And you had to have a certain condition in order for the doctor to prescribe the shoes. The program worked wonderful. Clients raved about it. The doctors raved about it. But when it became time to evaluate it, headquarters, and I'm sure it was deliberate, and I swear it was deliberate, I'm sure it was sabotage, they did not ask the right questions. As a result, the evaluation, in my opinion, was very flawed. It showed that there was no value in providing those shoes. And at the end of the pilot, there was no discussion from headquarters with the regions. It was a dictatorship role again. It said, we tried it, it failed. See, I told you it's not going to work, and we're not discussing it ever again. despite bringing it up every meeting, it has never been on the discussion table or on the agenda again. Recently, we've seen the dental program being centralized to Ottawa. That meant that the region no longer had any role in approving dental care. We're seeing the dental turnaround times gone from the requirement for the regions to approve predetermination or do the approval on dental was a minimum of 4 weeks, depending on the complexity of the case. But we had 4 weeks, and if we got behind, we worked overtime to get caught up. The requirement was 4 weeks. It's now gone to headquarters. I'm hearing from some of the dentists that they're waiting 3 and 4 months, and they still don't have approvals. We've got clients out there that need root canals. We got clients that need crowns, and they're not getting approvals. And I'm sure that I know many of you have those stories of wait times, and the frustration of the dentists. And I'm seeing many of you nod your heads, so I know that you're hearing the same stories that I have heard. Headquarters is not open to exceptions. And we heard that example yesterday from Dr. Martin, who talked about some of the changes that have come down. They're not considering the client, and they're not making decisions based upon common sense. It makes only sense for me if rather than have my tooth extracted and have a denture, I would like to have a crown. So yes, give me the crown. Pay what it would have cost for the denture. And if I have an insurance plan, that insurance plan may kick in maybe, or I can pay it myself if I wanted that bridge. So there's options that are not given to clients. We have dentists that are dropping out of the program. One of the things that I do want to point out to this group is that your biggest supporters are going to be your providers. They can make things happening for you. Headquarters is not, at this time, I believe, open to making changes, and they're not open to listening. I had a quick conversation with Darlene earlier and talked about process. And yes, AFN is at the NIHB table, but as I was telling Darlene, they're at the table, but there is a meeting before the meeting where NIHB staff are given basically a gag order, and we're told the party lines of what to speak or what not to speak on. So it's no longer a meeting where we share. It's a meeting of, we're going to tell you what we want to tell you, and it's too bad if you don't like it. That's what I'm seeing. And for me, that's not working collaboratively together, and it's not a team any longer. So we've lost that over the years. The other area that is, before I forget, providers are going to be your biggest ally. In one of the regions, there were some changes that came down in one of the benefits. And the provider stood their grounds and said, we're no longer going to provide for you. You're not paying us appropriately. You're trying to tell us that we now have to give you a complete list of every nut and bolt we put on that piece of equipment, and we have to tell you the cost of that nut. We have to tell you the cost of the wheels. We have to tell you the cost of the spokes. That's a lot of work. So we want to be compensated accordingly if that's your requirement. And headquarters said no. Those providers banded together. They advised headquarters are no longer providing services on a given date, and they were prepared to withdraw services. That mobilized headquarters very, very quickly. They're out to that region that next week. They negotiated with those providers. They now have a service. That provider is receiving the service that is required, or the payment that's required. So that is another ally that you can use. Don't forget about those ones. They will be speaking up for you. We had Dawn Martin here yesterday who spoke on pharmacy and then the association. I've heard her speak nationally. She speaks her mind. She's very down to earth. She's very common sense. And she will be providing assistance if you require it. Provider audits. I love this one too. This has been, and they're necessary. They're necessary to ensure that providers are billing properly. That's not to say that all the providers are bad providers, but there are some providers that will overbill and excessively. But part of what happens with providers when they're under audit, headquarters is very punitive in how they recover. And an example is, I had a pharmacy who got audited. Not going to look at her anymore. I had a provider that got, or a pharmacy that got audited, and he dispensed birth control pills, which is a benefit. But in one of the little boxes, he put the wrong number. Rather than put 28 days supply, he put 21 days, which is the number of days that the client had to take the pills. So what headquarters did is they recovered the total amount off of him. That included the cost of the drug, the dispensing fee. And even though we argued that he dispensed the birth control, they still recovered that amount. So in my opinion, that there was this punitive in terms of the provider. And I also had an opportunity to speak to one of the dentists yesterday, and the same situation there. It was mass recovery of a service that he provided. He provided over and above the standard. And again, they came in and they recovered a total amount from him. Those kind of things upset providers, and then they don't provide the services to our clients that they need to do. They don't take the care that they really should when they know that NIHB could potentially come back and recover the cost of the services. We've seen an implementation of a private mileage rate that doesn't even cover the cost of gas. You might get 3/4 of the way there, but hey, you got to go home yet. And again, despite regions saying it's not enough, they would pull out their little books and they would pull out their little calculators and they'd say, see, it works on paper. But common sense tells us that when you got a res car and you're trying to get to town to see the doctor, that sometimes that old res car can sure soak up the gas. So, and they didn't save any money on this. You know, we've seen other areas where clients were still getting the service, but now they're accessing the bus. They're accessing medical taxis. So there was actually no cost savings at all. In fact, it was inconvenience to the client now because no longer could they go to town, get their appointment done, get their shopping done, and visit family, friends, go to bingo, what the heck, and then go home. So they've lost that ability to be flexible, to manage their life, and to have a quality of life out there. Compliance packaging is another one that is not covered. A lot of the elderly people and the sick people need a reminder, and I did the same to myself, by the way. I went and got myself a compliance package because I forget. And if I don't have that reminder, I don't take my daily meds. So that is not covered, and I know some communities are actually picking up that cost from whatever budget they have. Since I'm running very short of time here, I just want to speak on one more item, and that is there is no requirement to provide proof of who you are when you access a benefit. You go into the provider's office, you give them your registration number, you give them your name, you give them your date of birth. They provide the services. Sometimes that's not a good thing. I was in the drugstore one night back home, and a gentleman came in, and he may have been Aboriginal. I have no idea. He may have been First Nations. I don't know. But he proceeded to give the drugstore a name and a registration number. They asked him his date of birth. He had to dig in the pocket to find out how old he was. I thought that was a little bit strange, but, I don't know if he was registered, but I don't know about many of you, but I'm very protective of my benefits. Those are owed to me. Those are my rights, and I certainly don't believe that people that are not eligible for those benefits should be taking my benefits away and using them. We seen that during the consent period of 2003. Some of you will remember the consent initiative, and don't throw anything at me. But there was an incident where somebody had actually signed a consent form for an individual that was deceased. Last but not least, I want to say one more thing. Nothing mobilizes the government more than flooding the minister's office with letters. In the government, priority one is any ministerial letter that they receive. So regardless of what you got on your plate for the day, regardless of what your priority is, when that minister's letter comes down, you drop everything else and you focus strictly on that letter. My suggestion to communities is do yourself a form letter. When you know of situations where a client has been denied or you've had an incident in your community, fill in that form letter with the date, the time, the little incident, fire it off to the minister's office, and let's see some reaction. Thank you very much for listening to me.
Thank you, Denise. And I know you have the template for that form letter. Okay, anybody have any questions here? We have a few minutes to ask any one of these ladies about any question.
Hi, my name is Marshall Draper from Big River Council. I have a question how much do we weaken our treaty rights by paying into insurance?
In my opinion, and this is strictly my opinion, you don't weaken your rights. You pay for that benefit. Right now, you are having your check deducted, and you are paying a fee to have that insurance. It's no different than having car insurance. You buy insurance for your car, you buy insurance for your health.
But, for me, I started paying into the insurance benefit a couple of years ago. And then when I went to get my glasses, like you said earlier, you're only covered for $60 from whatever. So I was told that all I had to do was send my bill to the insurance and they would cover it. So I did. I did all the things I'm supposed to do. And then they mailed me a letter back and say, well, who's your first insurer, which is supposed to be covered by my treaty rights, eh? So, I'm paying the insurance just to kick me back to whoever else is supposed to pay for my glasses and back and forth. It's just like you ask the federal government for something, they say it's not their responsibility, it's the province. And then you're kicked back and forth all the time. So, I didn't even process that letter because I don't want to pay into the insurance because my treaty rights should be covering my glasses.
Helen, did you want to speak on insurance plans? Helen Burgess is here. What a wonderful lady. NIHB worked very closely with her in her department, and she is my go-to person anytime there is a question on insurance.
I'm going to address the way our plan works, and it differs from all other plans out there. This afternoon, I'm going to explain to you exactly how our plan works in our lifelong attempt to help preserve and enhance treaty rights, but not ever replace or duplicate them. So my explanation on that will come later this afternoon. But in an attempt to answer this gentleman's question, yes, we as Status Indian people are entitled to having our vision needs met once every 2 years. There is a specified dollar amount that the federal government has determined should meet our needs. We know very well that that specified dollar amount falls very short of what is actually required. Therefore, we need that private insurance plan to back up those additional costs and provide us with what our vision needs actually are. So where, yes, we should not have to fall back on our private plans first and foremost, our treaty health rights should meet those needs. We do know, however, that they are not. And I will expand on that a bit later this afternoon. I hope that helps to answer that question somewhat.
So you're still in the same boat.
Like, my other question is, say, like our treaty rights are supposed to cover all our health benefits or whatever. And then, why should that money come out of my pocket when my treaty right was with health care? And now I'm paying from my pocket what was promised to our forefathers. And who lobbies for it? I'm going to need glasses for the rest of my life, but I'm not going to pay to that insurance because I believe that my treaty rights should cover it. The Europeans, when they got here, did they have a ship full of money that they brought here? Or did they get it from this land? They got it from this land. The taxpayers got it from this land. And it was never surrendered, and it never fairly negotiated, in my opinion.
Nope, I hear you, and if I was still a federal civil servant, I would be lobbying for you.
She can lobby for you. That's what.
But you couldn't talk like you would be able to talk.
Don't get her talking again. I'm trying to shut her up.
You were talking about diabetic shoes. On our reserve, they told us that the diabetics were going to get shoes. So they told us all the ones that were diabetics and the older people. So we all went to the band office, and the guy from Regina was taking our shoes, and he asked me, what size do you fit? And I told him. And he said, oh, no. You need size 11, he told me. Who fits size 11 here? And I still have them in my closet. So I don't think they're just shoes that they can't sell to the white people, so they bring them to the reserve, so whatever is what we get. So thank you. And another thing, you guys, our treaty rights are treaty card. Okay, it's no goddamn good to us now. We can't even pay, like we pay taxes wherever we go. You know, even in our hotel rooms, in our restaurants, but yet the civil service of Canada, the Indian Affairs, don't pay tax on their cards. I always remember here we went for health. They came, and I was asking questions, and I told them, how come you guys don't pay your gas? All you have to do is sign that paper, and it goes, and the government pays for it. We hold our treaty cards, we have to pay for that gas when we leave out off the reserve. So what the hell is the difference? What's the change? How come that treaty card is no damn good to us? And you guys can travel, even Indian Health. I remember when Indian Health came to our reserve, there was 2 vehicles and there was 2 people. And I asked them, do you pay for your gas? No, we just signed the paper. And the wear and tear of your car, do you pay for it? They said no. Well, how come we have to pay the wear and tear when we go and see the doctor? So it's not fair. You know, the white people come to our country and they think they're God to gift, that they can control the whole world. And yet, this is our land. And we were generous enough to give us to be fenced off on our reserve. It's 4 by 6, and we all have to live there. No wonder our generation are out in the cities where they're so poor and being sold with drugs and everything. You know, when in our day and age, when I lived on the reserve, we never left the reserve. We stayed there because our parents looked after us, and we looked after ourselves after we got married. So, you know, the white people always start wars. Look at the war that's going on with the Russians and the Ukrainians fighting for a while.
Thank you. I just wanted to say this part. You know, there are many studies on the urban push, the push and pull in from the reserves to the cities. She's bang on the outcomes, by the way. Anyway, those are just, I think, very commonsensical, and I always like those kind of people myself. So thank you, and I think that gives us some indication of sort of the importance of a strategy towards non-insured health benefit, which is just a program, by the way. It doesn't include all of health. It's just one thing. So, but we are tasked with trying to do something about this one thing, and it's going to be a long fight because I know I've seen health directors sitting here, and I've been a health director myself for years. It's been from way, way back, at least, I won't say 40 years. No, I won't say that. But anyway. Anyhow, lunch is here, and why is that not downstairs? Is there a reason? I just lied to these people again. The food, is it downstairs? So that's just... Okay, so that food sitting out there is nothing? Oh, there's muffins. Okay, go ahead and eat those muffins. Anyway, downstairs.
Okay. Yes, good discussions, and thank you so much for bringing in talking. Just plain fact, shoot from the hip, we need that. What's going to happen is there's 2 ladies at the door there. Elaine will help with the special needs and help guide the process into where you'd be going down with if wheelchair accessible and the elderly. Elaine will be the one that you follow. Just give them a wave, Elaine. And then the other lady Christine, she'll be guiding everybody else. What's going to happen is all the food will be ate in a different room. And as we're doing that, these tables in the back will be removed, and there'll be more tables added for people to sit and write, and there'll be more room when we come back. Thank you.
See you after lunch.